Okay, guys, good morning. I know that this isn't ideal, and I wanted to do this in person, but just with everything going on with the coronavirus, I think it's safest just to go ahead and make an online video that you guys can reference. Like I said, I will post the hemodynamics part one stuff, so you can reference that video. It's audio as well, and then I will also make copies of all of this paperwork so you guys can actually have this to look off of as well. So we're just going to start today for hemodynamics part two with shock. It's something that I think we all see a lot of, but there's several different types of shock, and I thought it was something that would be helpful and important to review. So there's four different kind of umbrella categories of shock. There's obstructive shock, cardiogenic shock, distributive shock, and hypovolemic shock. So we're going to start with obstructive shock. Simply put, obstructive shock just occurs when basically blood can't get where it needs to go. There's some form of blockage. So things that we'll frequently see that can cause obstructive shock in a patient would be a pulmonary embolism. Obviously, other signs that you need to look out for that is if you start to have oxygenation issues, if you start to have tachycardia, shortness of air, especially in a patient that possibly is at high risk for developing blood clots or fatty emboli that has recently been mobilized. So this just kind of causes an interruption or an occlusion to the blood flow leading to the lungs where we know the blood is oxygenated, and that can cause a form of obstructive shock. Additionally, there's other conditions that can cause a buildup of air fluid in the chest cavity that will also lead to obstructive shock, i.e. a pneumothorax or hemothorax. And I just put a picture there so you can kind of see the difference between a small pneumo, large pneumo, and then obviously when we treat a pneumo, you guys all know this, we either can alleviate that with a large bore catheter, but we most commonly place chest tubes just to let that lung reinflate. And then lastly is cardiac tamponade. I don't think that we see as much of this in the ICU. It's usually kind of taken care of downstairs in the ED, but it is definitely something worth mentioning. Cardiac tamponade is when fluids or blood can fill the cardiac sac that sits around the heart, and it just compresses inward on the heart. So you can kind of see in this second picture here, when you have fluids sitting around the heart in that sac, it compresses in on the heart, and it really decreases the ability of the heart to work. So you can see over here on the picture from the left to the right, the left ventricle, which is here, is significantly smaller. So the amount of filling time that is allowed is significantly less because the heart is being compressed. So you're not going to be able to get nearly as much cardiac output as you should be able to just because of the compression that's sitting on that heart. I mentioned it accumulates in that pericardial space there. Yeah, so this can be very serious and it can be very life-threatening. It needs to be alleviated as quickly as possible or else the patient can decompensate very quickly. That's going to kind of lead us into cardiogenic shock. This is kind of a tricky one, and again, I feel like a lot of times when we start to notice cardiogenic shock, the patient is already starting to decompensate pretty significantly. So cardiogenic shock is just when you have damage to the heart muscles and the myocardial cells that decrease the blood flow to your body. The heart is what pumps our blood out, so obviously any kind of damage to the heart is going to decrease the amount of successful work the heart is able to perform. So common causes of your cardiogenic shock, I think the most common that I found in looking through all this stuff was just a myocardial infarction, of course. Anytime you have ischemia or infarction to the cardiac tissue, it's going to cause a decrease in cardiac function. Any kind of irregular heart rhythms that can be significant, or a very, very slow rhythm if your pump isn't working efficiently. Basically, this is just as an umbrella statement, if the heart isn't working optimally, you can have a patient go into cardiogenic shock because you're not supplying the body with enough volume to make sure that you're hemodynamically stable. Next is distributive shock. I think we probably see this form of shock more frequently than the other two we've already covered. So this is any kind of condition that can cause your vessels to lose their tone or vasodilate. So this is not a volume issue, which is what's, I think, the most important thing to understand. Distributive shock does not mean that your patient is dry or that they are hypovolemic or that they need fluids. It means that the vessels are vasodilated and they have no tone. So of course, you're not volume down, but when all of your vessels in your body are very vasodilated or expanded, you're going to have hypotension. So you guys can read through this. I'm not going to read off a page to you. I'm just kind of trying to hit the high points here. But of course, your distributive shock can show up in patients showing flushed skin. If your vessels are very vasodilated, you're going to be really perfusing those capillary beds well, so they can be kind of warm and flushed. Obviously hypotensive, and then any kind of neurological change can occur, with shock, obviously. So distributive shock is an umbrella term, and these are the different types of distributive shock that we can see in our patients. Anaphylactic shock, I don't think we really see this very often, but this is just a very severe allergic reaction, and it can present, as side effects being distributive shock. So your vessels just, again, really relax and vasodilate in these areas. So they can be a food allergy and some kind of venom or insect sting, medications, or possibly latex, but that can cause a form of distributive shock. Septic shock, this is, I think, a common one that we see, obviously. It is a form of distributive shock initially. So you have a sepsis, which is, ideally we see it most commonly with some kind of bacteremia, which I'll get to a little caveat to that. It can be from other sources, not just bacteria, but it's just a condition that is caused by some kind of systemic infection that has gotten into the blood. And it leads to the bacteria basically entering the bloodstream and causing all of these changes in the body that will lead to the blood vessels vasodilating, which is where septic shock comes into play. I believe that Katie Hedges is going to make an entire meeting of the minds on sepsis alone, so I'm not going to get too much into the nitty-gritty here. But when your vessels start to vasodilate in one of the portions of sepsis to septic shock, that's when you're going to start to see the shock symptom of this. When sepsis progresses to septic shock, it's because you start to have that form of distributive shock. Another little to note here on sepsis is that it doesn't just occur from bacteria. It can also occur from viruses and fungi. So I had Dr. Reed just kind of read over these notes and make sure that everything sounded appropriate. And he said that specifically the medical ICU team really has an issue with us diagnosing patients with the term septic shock for a prolonged period of time, because septic shock is a secondary diagnosis to a systemic infection. So just to kind of make sure that we have this on our radar, if you do have a patient that you think is going from sepsis into septic shock, we need to have a reason why. So, of course, if you have a patient who has pneumonia that is then turned into sepsis, which has progressed to septic shock, we need to make sure we're treating that pneumonia. Versus if they have a UTI and they've developed urosepsis, we need to be making sure we're treating that urinary tract infection to basically eliminate the source of what's causing this patient to go into sepsis and then eventually septic shock. So just make sure if your patient is septic or they're progressing to septic shock that we have a reason and we know why they're going into septic shock, or we're working them up for the source of infection. Neurogenic shock. This one I think we kind of forget about, but it's super important. We'll see this a lot in spinal cord injuries. So it's just because of the injury to the cord most typically, or any portion of the central nervous system that has had damage occur to it, the patient loses that vascular tone. So a lot of times, I know we've all taken care of many cords with the neurosurgery team, their heart rate's all over the place, their blood pressure can be very labile. So it's important to understand that when you have a spinal cord injury, that they can go into neurogenic shock just because the innervations from their cord can cause those blood vessels to dilate and lose that tone. Again, you'll see the skin feel really warm and flushed, their heart rate can be very slow, and their blood pressure can be very low. They'll get hypotensive. And then drug toxicities and brain injuries can also lead to distributive shock. That's just kind of another little side point. I think most commonly what we see working in the trauma ICU is hypovolemic shock. I don't really feel like I need to hit hard on this one. It basically happens when there's not enough volume in your intravascular system. So if your patient is hemorrhaging, is usually the most common cause of hypovolemic shock. Obviously, you just need to replace their volume. I know that we work with trauma and we usually replace pack cells to FFP 1:1, so just don't forget about making sure you're replacing all of the products when your patient is in hypovolemic shock. And then additionally, don't rule out dehydration. So if your patient is had a little bit of blood loss and we've replaced their blood products pretty appropriately, but they haven't had a massive amount of blood loss, just consider the fact that, dehydration can also be a reason that they go into hypovolemic shock. If they've had the flu or they've been sick for a prolonged period of time, they may just need crystalloid fluid, and that will help. Next, we're going to go into cardiac dysfunction. I really am only covering this kind of vaguely just to lead into Arctic sun management. So you guys feel free to leave any comments below, and I'll be happy to either look up the answers if I don't know them. Again, I had Dr. Reed look over this. So this is just like very, very broad. We're just going to kind of touch on these few different things. So going from kind of least serious to the most serious form of cardiac dysfunction, we're going to first cover angina. Angina is just chest discomfort. It's pretty vague and it can be kind of nonspecific, but angina is just caused by poor blood flow through the blood vessels or coronary vessels of the heart. So there's two types of angina. There's stable and there's unstable angina. Talking about angina, both unstable and stable angina, it's important to note that the symptoms are present in angina. Your patient has chest pain, they have maybe shortness of air, they have subjective symptoms, but there are no signs of cardiac damage, meaning there are no elevated cardiac markers like troponin. There are no EKG changes. So your patient with angina will have chest discomfort, they will have possible chest pain, they will have shortness of air, they can, but they will not have physical markers that they are having any kind of cardiac damage. So stable angina is when you just have chest pain or discomfort with increased activity. So when you increase the cardiac workload is when you're going to notice that you have chest pain. Your patient's walking up a flight of stairs or they start to run, and if they have an occlusion in those coronary vessels, it will obviously, their oxygen supply is increased and their heart can't meet that demand. So the nice thing about stable angina being the less worrisome of the two, stable versus unstable, is that once that activity stops, the chest pain will go away. That patient obviously should probably still be seen by a cardiologist just to ensure that they don't need to have any kind of stent placement. But stable angina gets worse with activity or emotional stress and goes away once that activity or emotional stress goes away. Unstable angina, so this is, your patient can just be sitting on the couch and all of a sudden they start to have this, acute chest pain and shortness of air possibly, but it will eventually go away. And like I said, there are no signs of cardiac damage if you look at an EKG or any kind of blood work. This obviously can precipitate or lead to a myocardial infarction, considering the fact that the patient is not increasing their oxygen demand and they're just randomly having this chest pain. So the most common causes of angina, I'll scroll down so you can see these pictures in just a second, are coronary artery disease due to atherosclerosis. There's a few other reasons which I'll cover in just a second, but when you have this plaque buildup here inside those coronary vessels, obviously you can have a decreased amount of blood flow and oxygen perfusion to the heart just because of the occlusion of these arteries and vessels. Atherosclerosis, I know we should all probably be familiar with that, but it's just a buildup of fatty material called plaque along the inside walls of the arteries. So it just, like I said, decreases blood flow to the heart and decreases oxygenation of that myocardial tissue. So the vessels will become narrow and less flexible in addition to having that plaque buildup, and it can just reduce the blood flow. Other things that can cause angina symptoms are cocaine use. So obviously when we have a patient come in, this is again more so done in the ER, but we should be getting a tox screen on these patients to ensure that it's not drug related that they're having this chest pain and possible shortness of air. Hypovolemia, which makes complete sense. If you have a loss of volume in the intravascular space, the amount of volume that your heart is going to get is going to be decreased. Anemia, if you have a deficiency of red blood cells, your oxygen carrying capacity is going to be significantly lower. And then any kind of arterial vasospasm, that's just, if those vessels are starting to spasm and close, it's going to act very similarly to just like an atherosclerotic vein or vessel would. It's a decreased space in which the blood has to move from one area of the body to another. I think that's pretty much it with this. You just have to basically think about, could it be a physical change, or could it also be a chemical change that changes, the amount of blood getting to the heart? Interventions with this, from least invasive to most invasive, just lifestyle changes. If these patients are obese and they have a terrible diet and exercise regimen, just changing their lifestyle can help, increase their cardiac function. So healthy diet, exercise, all that good stuff. Anticoagulation, if it is clots that could be building up in these areas causing a lack of perfusion, anticoagulating the patient can help prevent future clots from forming. Cath lab is more invasive, but sometimes they'll do percutaneous intervention, or PCI, which will include a balloon inflation, sometimes just to inflate that area and then removing the balloon, or more invasively using a balloon to inflate the vessel and then placing a stent. Excuse me. And then most invasive would be a CABG, or a coronary artery bypass graft. I feel like usually it has to be pretty significant for them to want to do a CABG. Now moving into myocardial infarction, I think it's important to cover these two terms just to make sure that they make sense. So you have ischemia versus infarction, and they are different. Ischemia is when you just have a diminished volume or decreased perfusion. So your patient isn't getting as much oxygen as they should. And that can be anywhere. You can have ischemia to your, foot, your heart, your brain. I mean, any kind of ischemia as a global term is just you're getting a decreased amount of volume and decreased perfusion, which means that that area that is ischemic is not getting an adequate amount of oxygen. Where infarction is, it's gone. There is no perfusion. The cells are dying. There is no oxygen being perfused to that area. So that's important when you talk about cardiac ischemia versus cardiac infarction, because ischemia we can fix if we figure out the source of the ischemia. Infarction, the cells are dying, so time is cell death, really. I'm going to go into non-STEMIs and STEMIs. So this is just a nice little representation of what they would look like very, basically on an EKG. Obviously, getting a 12 lead is always the most, informative thing to do in these situations. But you can see at the very top here, we have a normal EKG. Your ST segment is level with the isoelectric line, which just means that you kind of place a ruler or even just your finger across that line, that ST segment doesn't waver above or below that line that the base EKG is running on. If you bump down just one, you'll see a STEMI. Obviously, that is extremely elevated. It's very abundant and obvious to see that patient would have ST elevation. That is a huge issue, and like I said, I'll cover that in just a second. So when you have a non-STEMI, it can present in a few different ways. A non-STEMI just stands for a non-ST elevated myocardial infarction. And again, I'm going to cover both of these in more depth in just a second. But you can have what's called ST depression, and you can see that on this third EKG representation here. So ST depression can be indicative of cardiac ischemia, which can be, not always, but can be impending that infarction could be just around the corner, depending on what's going on with the patient. So if you see ST depression, it's definitely worrisome. We definitely need to make sure that we're alerting the physicians of this. And the same goes with the last thing here, T-wave inversion. So if you have a patient who has a T-wave inversion, there's a few different things that can cause this. However, cardiac ischemia is one of them. So it is important to make sure that we kind of rule out that the patient is possibly having a non-STEMI. Chris also told me that you can also see T-wave inversion with intracranial hemorrhage, which I did not know that. So that is helpful to know if we have patients who are watching, closely with neuroexams and they start to show a spontaneous T-wave inversion. It could possibly indicate that they're having a spontaneous intracranial hemorrhage. So bouncing down to, again, a non-STEMI, which is a non-ST elevated myocardial infarction. Infarction meaning cell death is occurring. The difference between these two, non-STEMI and STEMI, is that with angina you had just symptoms and no signs, and I mentioned that. So just chest pain, other subjective symptoms that the patient is experiencing, but no elevated cardiac markers, no EKG changes. When you come down to STEMIs and non-STEMIs, there are both signs and symptoms. So the patient is probably having that chest discomfort, chest tightness, shortness of air, possible referral pain symptoms, in addition to having EKG changes and eventually elevated cardiac markers. So looking at diagnostics for a non-STEMI, you will have, I already said these, the possible subjective symptoms. And then we're going to draw blood work that will take a look at the cardiac markers. Troponins are most typically what we will draw. Second, or kind of simultaneously, we'll also be getting an EKG of the patient's heart to see if there is any kind of EKG abnormalities. Now, on a non-STEMI, you're not going to have any kind of ST elevation, but it is possible that you could have T wave inversion or ST depression. I think pretty much that's the big takeaways from a non-STEMI. Chris did kind of enlighten me with the fact that there's actually 5 different types of non-STEMIs, which that's, very invasive for us to know. But he did share this small little tidbit that most commonly in our patient population, we'll see what's called a type 2 non-STEMI, which is a supply-demand mismatch. And we've kind of talked about that already with cardiac ischemia. When your patient, isn't perfusing well or has ischemia or infarction, they're not getting the appropriate amount of blood and oxygen to the areas that they need. Interventions with a non-STEMI, anticoagulation, possible cath lab or percutaneous intervention. This only happens, though, when the patient is unstable. So kind of like angina, with a non-STEMI, I think they more so will probably anticoagulate the patient and then just monitor the patient to make sure that nothing gets worse. However, if the patient is hemodynamically unstable, they absolutely will take them to the cath lab and do percutaneous intervention if need be to reperfuse the heart. They're usually, like I said, non-emergent issues, but they can be depending on the stability of the patient. STEMIs are much more pressing and much more dangerous. So if you suspect this, plain and simple, we need to call the doc. If you look at the patient's EKG and you think that there's an ST elevated segment, we need to go ahead and just put in for labs and an EKG. We need to let that physician know immediately so they can get cardiology on board as quick as possible. Diagnostic criteria is very similar to a non-STEMI. You have the subjective symptoms, and then you would also have elevated cardiac markers and EKG abnormalities. It is important to note, which I'm sure a lot of you guys already know this, that initially when a patient starts to have a cardiac event as far as ischemia or infarction occurs, you may not see elevated cardiac markers or troponins. Those can take a while to elevate, up to 2 to 4 hours, which is why we trend troponins, because we're allowing basically the body and the heart to react to this ischemic or infarcting issue and then see kind of how the heart has responded by trending those troponins. A lot of times, and this is completely up to the doctor's discretion, we will trend cardiac markers or troponins until the patient peaks and starts to trend down for 2 lab draws, and then typically after they're trending down for 1 or 2 lab draws, you can stop trending those troponins. I thought this was interesting. The nice thing about EKG, a 12 lead, which this is not really within our scope, but it is always cool to learn. You can look at the 12 lead, and it's an invasive way to read it, but it will tell you which areas of the heart are infarcting. So these were just kind of a picture that I found that's interesting. So based on where you will see ST elevation or EKG abnormalities, tells the cardiology team exactly which portion of the heart is infarcting. So I thought that was kind of cool. Interventions, we got to get the doctors down there ASAP. That's the most important thing because time is cardiac tissue, especially with a STEMI. And if that tissue is infarcting, we're not going to get it back. So the quicker we can intervene, the better off the patient will be. Cardiology should absolutely be on board for patients who've had STEMIs, anticoagulation, obviously, and then cath lab or percutaneous intervention. Next, we're going to hit cardiac arrest. This could be a whole lecture in its own, so I'm not really going to talk about this much. We've all coded patients. Our ACLS instructors could probably educate 1,000 times better than I could even dream of. But cardiac arrest is when we have an abrupt loss of cardiac function. The patient is pulseless. We need to provide ACLS. If you guys want to do a meeting on it, I'd be happy to loop somebody in who's more informed on this topic than myself and is actually a certified ACLS provider. But I really just wanted to mention cardiac arrest so it could kind of lead us into our next point, which is the Arctic Sun. I did create an additional page with all this information so I can keep it posted on the unit, just as a quick reference if we ever have to set up a patient with the Arctic Sun. I want to preface talking about the Arctic Sun by saying anytime we have a patient on the Arctic Sun, we've got to pull out the protocol and look at it. It's actually super helpful. It's very detail oriented. It's really not a lot of extra mumbo jumbo that you don't need. It's very, very concise and very informative. So if you have a patient going on the Arctic Sun, please pull out the protocol. I'll attach the protocol with all this paperwork when I hand it out and just go kind of from start to finish based on the protocol. It will really help. So this is just kind of the high points and more specifically the setup, which is what I really wanted to cover. So here's a picture of the back of the Arctic Sun. It just kind of covers, the labeling parts, where you plug everything in. Typically this is already set up when we grab this machine from 6 West. So a few things to know prior to placing the patient on the Arctic Sun. Typically the indications for a patient going on the Arctic Sun is that they have gone into cardiac arrest and ROSC was achieved. There are a few contraindications. I definitely look at those on the protocol before you even consider setting a patient up for this. But MICU is usually pretty good about making sure that the patients are appropriate for this intervention. So first off, prior to setup, we should look at a few things. We should not be putting these patients on this if it is greater than 8 hours from when we achieved a ROSC. So the quicker you can get them on the Arctic Sun and begin hypothermia protocol, the better outcome they are likely to have. So initially, the patient's got to be mechanically ventilated. That's just plain and simple. Very heavily sedated, and we used to always begin these patients on neuromuscular blocking agents to stop shivering. If the patient is on the Arctic Sun, they're going to be really, really cold, and we do not want them shivering. It increases their metabolic demand, and basically, it's pointless to have them on this blanket and on this machine if they are shivering. So recently, MICU has not wanted to paralyze the patients, which is okay, but if they are not paralyzed, we need them so heavily sedated that they are not shivering. If they start to progress to shivering, then I think a neuromuscular blocking agent is appropriate to ask them, to ask the physicians for. The patient has to be hemodynamically stable before we put them on the cooling blanket. And then reliable IV access. Like I said, they're heavily sedated, often chemically paralyzed, so usually a triple lumen is already in these patients considering that they've already coded. But some kind of really good reliable IV access is required to start them on the Arctic Sun. I mentioned refer to the protocol 1,000 times in here. Like I said, it's very helpful. I just kind of pulled out some of the most important points I thought. So initiating the patient. Initiation should occur as soon as possible after we obtain ROSC. And typically the cooling temperature fluctuates between 33 and 36 degrees Celsius. Look at the order set because they can change that. But per our protocol in Cerner, that's the range that they have listed. You want to rapidly cool the patient when you initiate. So typically within the first 4 hours of the protocol, the patient should be cooled to the target temperature. If you're spending 8, 10, 12 hours to cool the patient, it's defeating the purpose of putting them on the hypothermia protocol. And then close monitoring of labs and blood sugar. So there is an order set that needs to be initiated when they put in the power plan for the Arctic Sun. And once you initiate that, it'll have you drawing frequent labs and sending an initial panel of several labs just to make sure that we understand what's going on with the patient. As far as maintenance goes, maintenance is really pretty simple. So once you get the patient cooled to the desired core body temperature, you just let them hang out there, usually for 24 hours. Again, that can change depending on what the physician wants and what the order set says, but that's like our standard. Keep them cooled for 24 hours. And then this was another small note that Chris also made I thought was really interesting. So because the patient is febrile, or could be febrile, we're not going to know it because we are specifically cooling them. So once we get into the setup, I can show you on here where you can actually take a look at the water temperature, because the water temperature is what's going to adjust to make sure that the patient stays the desired temperature. meaning if the patient starts to get too cold, the water temperature will heat up. If the patient starts to get too hot, the water temperature will cool down to keep the patient at a very steady cold body temperature. So if the water temperature is swinging very drastically, it's changing a lot, that's a pretty good indication that the patient could actually be febrile. And this is important because if the patient is being cooled and then staying cold and then being rewarmed for 48, to 72 hours, we may be missing a systemic or possible infection in the patient. So just pay attention to this. And whenever we do have a patient on this, I'd be happy to show anybody who wants to see it. But watch your water temperature in addition to making sure your patient's temperature is where it should be. Because the swing in water temperature can indicate that the patient is actually fevering, and we don't want to miss any kind of infection that's possibly occurring. Lastly, rewarming the patient. This is pretty easy, and I'll get to how you set it up, but you basically just switch them to the rewarming feature, and then the machine will kind of take it from there. It will slowly rewarm them in a controlled setting, and then it'll keep them at a normothermic temperature for however long the physician desires. So that's, again, based on the order set. Okay, this is the most important part I thought would be helpful. So as far as setup goes, first, you have to attach the pads to the patient. So I'm going to go over kind of how to attach the pads, then lastly, how to set the physical machine up. So you attach the pads to the patient. I put a picture on here for reference. It's really only 4 pads. If you have a bariatric patient that's extremely large, you can also get an additional pad or an additional 2 pads to put over the abdomen if those side pads that wrap from the back to the front don't even come close to touching. You want these to be directly on the skin. You don't want anything underneath them. And then every 4 hours when you're doing your assessment, we should be just peeling those back quickly just to kind of make sure that the patient's skin is intact underneath the pads. Next, you will just secure the tubing connections. I wish I had a better picture of this. I did attach a video at the end that's kind of lengthy. It's 15 minutes, but it is really helpful in understanding how to set them up, and you could kind of go along with the video. So when you clip the pieces into the water hose there, so the pieces in the demonstrator's right hand are the little cord pieces that are connected to the patient, and then the big gray piece there is the cord that's connected to the machine. So one side has a blue stripe and one side has a white stripe. When you plug them in, you just got to match up the blue to blue and white to white, or else it won't work. To disconnect the pads, we really shouldn't need to do this, but in case you're traveling or something, then you have to squeeze those little plastic prongs to open up the little clip, and then you have to push into the gray piece and then pull out. If you just squeeze it and try to pull, it won't release the pad. So you have to squeeze, push in, pull out. So once you start to get to the machine setup, you go ahead and hook all the pads up to the patient, make sure that all your lines and stuff are secure, your patient's sedated, and all that good stuff before you start to turn the machine on. Once you turn the machine on, you'll see this setup screen. That's just the opening screen. There is a button at the bottom right corner that's new user training. It is actually super helpful. Again, it's kind of slow and lengthy, but if you really don't know what you're doing, watch the video and it will clear things up. Next, the machine will perform a self-test, and then when the self-test is completed, the patient therapy screen, which is the screen below here, will pop up. You basically just have to pick normothermia or hypothermia. Initially, when we're starting this, we're obviously going to pick hypothermia, so you would select hypothermia and it'll prompt you to the next screen. Filling the reservoir, our reservoirs are typically filled. I think we kind of leave them full at all times, but in case they're not, that's just the water that we put into the machine that's going to actually circulate through the pads to cool the patient. So here's instructions of how to fill the reservoir. It takes 4 liters of fluid. You just put some sterile saline or distilled water in it. And then here's a screen. So you'll actually have this screen pop up on the bottom left here once you select the hypothermia option. Then you'll just need to hit the fill reservoir button, which if you see here is labeled N and is in Nancy. And then this screen on the right will pop up. So it'll say insert and fill the tube. It'll tell you where to fill it up, and then it'll say start to begin the cycle. So just make sure that your reservoir is full with water before you start the patient. Then you've already selected hypothermia, so you'll just go back. It'll take you back to this screen once you ensure that the reservoir is filled. And from there, you're going to then reference your order set and make sure that you understand what the targeted patient temperature is. That's really important. So you'll hit in this box labeled A. It's just a touch screen. So you'll click in the targeted temperature box and select whatever the desired temperature is. Again, our order set typically says somewhere between 33 and 36, but just check with the doctors and make sure we know where they want to keep the patient. And then you'll set the duration. Again, typically 24 hours, but it can vary. From there, all you do is hit start. So it's in that same box labeled A. You set your target temperature, duration, and then hit start, and then the cooling process will begin. The video I attached goes over this as well. That little white Arctic Sun machine under the letter H will start blinking when therapy is being initiated. So that's how you can kind of look at your screen and know that the therapy is going, is that white little Arctic Sun machine under the H will blink. That's it for cooling. So you just leave the patient on that for the desired amount of time. And then after that time is set, a lot of times if the machine is set up correctly, just normally setting it up, you should already automatically kick into rewarming once the 24 hours is up. Usually we're really pretty good about telling each other 24 hours will be up at, noon today or whatever time it'll be. And when that happens, I usually just go into the room around that time and make sure that it has kicked over to rewarming. If it has not, it's super easy to switch it manually. All you do, here's your picture. All you do, and you can see we're still on the hypothermia machine, you would just then go to box B and select your targeted rewarming temperature. That's typically 37 degrees Celsius for us, but look at the order. And then the duration of how long they want to rewarm the patient. And then once you set those two things, you just hit start in the rewarming box and it will start to rewarm them. It will switch them then to the normothermia screen. So as a little tidbit, if you're not sure which mode the patient is on, if you look in this top center area, you can see in this picture the patient is on hypothermia here. Once you switch them, it'll switch to normothermia once they get rewarmed. So that's a kind of quick and easy way you can tell whether or not the patient is being cooled or warmed. And then again, you can see the patient's temperature here in the top left corner, 36.4 degrees. And like I mentioned earlier, over here by the H, 24.3 degrees, that's your water temperature. So just kind of keep an eye on both of those things. If your water temperature is swinging drastically, your patient may be fevering. I, again, will hand out all this paperwork. Here's a link. It's really helpful and very informative. It goes over how to put the pads on. It goes on how to set the machine up, so how to fill the reservoir. It's very helpful. When in doubt, if you ever need to set up an Arctic Sun and you don't have anything for reference, which hopefully you'll have this paperwork, just look at the video. It walks you through step by step. Lastly is Swan-Ganz. This is really, again, just kind of a broad overview of this material. This is super in-depth material that we could get into, but we're not CCU nurses. We don't see Swan-Ganz every day, but I thought it would be nice to cover as a part of hemodynamics because we do occasionally get one of these, and it's really helpful to understand what the numbers mean and what we're looking at. So you can see this picture just kind of shows you where the swan goes. So a Swan-Ganz catheter is obviously invasive. It's threaded through a cordis, usually always, and it's just used to monitor the patient's heart function along with blood flow and pressures in and around the heart. So it's really a very informative piece of equipment, but again, it's pretty invasive. So the catheter is floated into the heart. A cardiologist will do this. Nurses do not ever even consider doing this. Sometimes they do it at the bedside, sometimes they do it in the cath lab. So they just float the catheter in. It goes in through the inferior vena cava typically, or it can go in through the IJ. It goes into the right atrium, down to the right ventricle, through the pulmonary valve, and then it sits in the pulmonary artery. And this allows us to look at a lot of different functions of the heart, which I'll get into in just a second. So I'm going to start by going over measurements. I know this is a lot of words. I do have pictures later. If you guys have any questions, please ask me. I studied a lot, just kind of refreshing on this material, and I'm happy to explain anything that doesn't make sense. So the first measurement we're going to look at is what's called your pulmonary artery pressure. There's a lot of abbreviation in here, so it's not as lengthy, but that's PAP, your pulmonary artery pressure. This is kind of an umbrella term. So your pulmonary artery pressure looks at two different things: your pulmonary artery systolic pressure and your pulmonary artery diastolic pressure. And that's what this means here. So your pulmonary artery pressure is just your systolic over your diastolic, just like a normal blood pressure, but it's looking at those pressures from within the pulmonary artery. So we're going to start with systolic. Your systolic pressure, your pulmonary artery systolic pressure, is normally between 20 to 30 millimeters per mercury. So your systolic is created when the right ventricle is squeezing into the pulmonary artery. So if you think about where the tip of this catheter sits, up here is a picture for reference. When your right ventricle is squeezing the blood to the pulmonary artery, that is what your pulmonary artery systolic pressure is, which makes sense. It correlates with ventricular contraction. Your pulmonary artery diastolic value is normally 6 to 12 millimeters per mercury. And your diastolic is what you get when the pulmonic and aortic valves are closed and the mitral valve is open. That's just what's happening in the heart. So basically, your diastolic pulmonary artery pressure, it corresponds with your left ventricular end diastolic pressure. So if you look up here again, your pulmonary artery diastolic is your left ventricular end diastolic value. So when the left ventricle is right at the max point of filling at the end of diastole, that is going to be what your PAD, or pulmonary artery diastolic pressure, is. I hope that makes sense. However, it is important to understand that your PAD very typically correlates with your left ventricular end diastolic pressure. However, there are a few cases that can alter that number. So if your patient has some things such as mitral disease or pulmonary hypertension, it's important to understand that those numbers may not correlate appropriately, which is just good information to know, because if the cardiology resident comes by and wants to know what those numbers are, it's important for us to know, which, like I said, we're not CCU nurses, but it's important for us to know kind of what that baseline echo or TEE, transesophageal echocardiogram, looks like, because if that patient has cardiac abnormalities at baseline, it could skew our numbers. Our pulmonary artery diastolic pressure could be off because of those other things, other abnormalities. Next, we're going to look at a wedge pressure. I'm going to preface this by saying a nurse at University Hospital does not ever wedge, ever. Some facilities allow nurses to do wedging, but it's really can be very dangerous. So a pulmonary artery wedge pressure, we get that when you inflate the balloon at the tip of the catheter. When you inflate that balloon, you very temporarily occlude that pulmonary artery, which allows us to look at the left side of the heart. So the nice thing, and I'll get to this more about a swan, is by occluding that balloon at the tip of the catheter, you can kind of look at the left side of the heart versus the right side of the heart in the pulmonary system. So it gives us a lot more information. I know it's very invasive, but it really does give us a lot of information. So your normal value is between 4 and 10 millimeters per mercury. It reflects your left atrial pressure. So by occluding the balloon, you block that pulmonary artery, and it lets us look at the left side of the heart. An elevated wedge pressure could indicate left-sided heart dysfunction. So let's go back up to the picture here. If you look at this, when you occlude this balloon, basically we're occluding the pulmonary artery, which is not giving us numbers from the left point of the balloon, if that makes sense. So we're getting our numbers from the tip of the catheter here, which is going to then look at the left side of the heart. So occluding that balloon, we kind of block out the right side of the heart, and we look more specifically at the left side of the heart. As far as numbers go, your PAD, pulmonary artery diastolic pressure, your LV EDP, abbreviated for left ventricular end diastolic pressure, and your wedge pressure should all be relatively the same. Your wedge pressure is usually a little bit lower than your diastolic just because of the pattern of blood flow. Your blood flows from a higher to lower pressure in order to move forward. So your wedge is going to be a tiny bit lower. But it's helpful to know that those numbers should all be relatively close. Granted, your patient does not have underlying other cardiac issues that'll throw your PAD off. So it's important to know that your wedge should not ever be higher than your pulmonary artery diastolic. If your PAD is higher, it could be caused from an overwedging, it could be caused from a misplaced catheter tip, or it could be caused by elevated PEEP just because you're changing the intrathoracic cavity pressure. When looking at, this was another little tidbit Chris added in here that I thought was helpful. When you're looking at elevated right heart pressures, which is your CVP basically, why is my CVP high? The wedge can differentiate the lungs from left-sided heart failure, or left-sided, left ventricular failure or dysfunction. So the nice thing about the Swan is that you really, if you have an kind of unknown or undifferentiated shock or cardiac dysfunction, and we really don't know what's going on with the patient, the Swan can give us a lot of useful information. So if you look at your patient's CVP, which you can get from this catheter, that's going to be the blue port, which we will go over in just a second. If the CVP is high and the wedge is normal, if you think about that, it's most likely going to be a lung right ventricle issue. So you're looking at the right side of the heart in the pulmonary system, not the left side of the heart. If your CVP is high and your wedge is really high, you're most likely going to be looking at issues with the left ventricle or left side of the heart, which he listed some examples here: stenosis, regurg of the aortic valve, mitral regurg or stenosis. But this is, as a whole, why the Swan is so helpful, because, like I said, in patients who have undifferentiated shock or possible high stroke volume variance, we can better assess what's going on. Is it coming from the right side of the heart and the lungs, or the left side of the heart? Or is it systemic? So here's a picture of what our Swan at U of L looks like. I know it's just a drawing. I didn't have an actual Swan to take a picture of, but I am going to get together with 7 West and make a video of how to set it up so you guys can actually see what ours look like. So there's a few different ports. I will go over the different ports. First off, we're going to go over the PA, the pulmonary artery distal port, which is our yellow port here. There's 2 yellow ports. You can see at the bottom there's the thermistor connector, but that's not the one I'm talking about. I'm talking about the other one that's labeled PA up here, distal lumen hub. So this is the largest opening, and it rests in the pulmonary artery and relays the pulmonary artery pressure continuously. So this is the port that we use to obtain a wedge. There's a special syringe. I really didn't want to go over this a ton because, like I said, we don't do this. But there's a special syringe that the physicians will put on that PA distal lumen, and they will inflate the balloon to get a wedge pressure. We also use this port to obtain what's called mixed venous blood gases. And I kind of cover what a mixed venous blood gas is a little more in depth here. This is very in depth. I know it's probably a little bit too much information. Chris gave me all of this information. I thought it was really helpful. And if you guys have any questions on this or it doesn't make sense, I'd be happy to reach out to him and have him educate us on it a little more. So a mixed venous blood gas should be obtained from the Swan, not from a central line or any kind of other area of the body. The reason that they have a mixed venous gas in the Swan is because it's actually a blood gas that's pulled from the pulmonary artery where both your systemic and cardiac venous blood is mixed. So it really helps us differentiate low output versus high output states of the heart. I'll kind of quickly go through this, but like I said, if you guys have more questions or want to know more about this, I can reach out to him. So a normal mixed venous SAT, or SVO2, which is for the venous, is approximately 65 to 75%. If it's higher, basically the body isn't using our O2 properly, or we're not taking the O2 up. We're not absorbing the O2 the way that we should be. So you can think of it as the blood is kind of going very quickly through the body, which doesn't allow for us to extract the O2 off of the blood. When your SVO2 is high, it means that your O2 is returning to the heart normally. So this, examples of this are going to be sepsis, high output heart failure, or shock. And it kind of partially explains why your lactic acid is high in these patients, because they're not using O2 for aerobic metabolism. When it's low, it's very slow, okay? So your blood is moving very slowly through the body. That's going to be less than 65%. So basically, this is kind of nice because your body has more time to try and extract the O2 from the blood. So this is going to be more instances of cardiogenic shock or hemorrhagic shock, where the hemoglobin and O2 carrying capacity is significantly reduced. So let's go back up to the picture here. We're going to look at the proximal or blue port, which you can see is right here. It's the shortest port. Like I said, that gives us a measurement of our CVP. So this opens to the right atrium, which is where our catheters usually sit when we are looking at our CVP, is the right atrium. So it attaches to just a pressurized continuous normal saline infusion with a transducer, and it is used to assess our CVP. It's also our injected port when measuring cardiac outputs. So when we go over setup, I will talk about that a little bit more, but basically you do have a patient that has a swan. Every so often, depending on the physician's order, you will use this port to inject basically room temperature or a slightly cool water to assess how quickly the patient gets rid of that temperaturized or cool water, and that tells us a lot about the patient's cardiac output. The balloon port or the red port, here's your balloon inflation valve. So this is where your syringe should be connected at all times. So this port will allow for your physicians to inflate that small balloon and get a wedge pressure. I apologize. I believe I said earlier up here that we did that. We did that with the PA port. So this is the portion, let me clarify. This PA portion, or the distal yellow port here, is used to obtain wedge readings because that connects to the tip of the catheter. So the yellow port is the portion of the catheter that physically gives us the number, but it is not where the syringe goes. I apologize. The balloon inflation valve, or the red port, is where the syringe stays. The PA distal lumen is where we can get the mixed venous blood gases, and which portion of the catheter actually gives us the number of the wedge reading, if that makes sense. So the balloon inflation valve is where the syringe goes and where the physicians will inflate the balloon. The thermistor lumen, or the yellow lumen with a red cap, which I have, sorry, I keep going back and forth, up here, this lumen. That is the lumen that measures the change in our blood temperature. So this also assists in measuring that cardiac output by measuring the duration of time it takes for the heart to pump out the cooler room temperature fluid. So like I said a second ago, that blue port is where we inject the solution, and then the thermistor lumen is what assists in helping us measure the temperature of that fluid in the heart to help determine the cardiac output. And then lastly, the RV pace port, or the lumen hub. That's just the orange port. We don't really use this a ton, especially considering we don't get swans a lot. But it's just used for either IV infusions, which is most commonly what we use it for, or for pacing the heart. So if the patient does need a pacemaker or needs pacing from inside the heart, we can pass a pacing wire through it and pace the heart that way. I hope that all makes sense. I know that that's not something we're very familiar with, and if you guys need more clarification, like I said, I'm happy to try and provide it. And I could also reach out to Chris and have him maybe do a little bit more information if you guys want it. This screen I thought was helpful. It just this is what a screen would look like on our monitor if we did have a swan. So you can see, you've got your heart rate, your blood pressure. These yellow numbers, that's our peripheral artery systolic pressure, which is 43, and our peripheral artery diastolic pressure. So that kind of shows us our normal swan, what a normal swan reading would look like on the monitor. This cardiac output portion, I will have one of the 7 West nurses go over how to kind of do that with us. I've seen it done before. It's really not hard once you figure out how to set it up. But basically, that's for the thermodilution. So to check your patient's cardiac output, like I previously mentioned, you put, usually I think it's 20 cc's of cold water in through the blue lumen of your swan catheter. You have to push very steadily and evenly. You do it 3 times, And basically that will end up giving you your cardiac output number once you shoot that water through there. You do it a few times, like I said. And I'll cover that again and more in depth when we make the video. Lastly, here's your waveforms. So this is kind of interesting because you can actually, if you've ever helped a physician float a swan, see what portion of the heart it's in based on your waveform on the monitor. It's kind of scary because a lot of times when they are feeding through the right ventricle, you will see the patient go into VTAC, what looks like VTAC. So initially when they thread the catheter, you'll see this EVP, which allows us to know that the tip of the catheter is in the right atrium. When they progress through the tricuspid valve to the right ventricle, you'll see more of a VTAC looking rhythm. And then once the physician places the catheter in the pulmonary artery, you can see that waveform there. And that's exactly where the catheter should be placed, is in the pulmonary artery. When they wedge the balloon, or wedge the catheter, which is when they inflate that balloon, that's the waveform you'll see when you have a wedge pressure. Again, if you ever see this wedge pressure, your balloon is inflated, it should only be very, very temporary. They should be standing in the room to get a wedge pressure, and then the balloon will be deflated as soon as they're done with it. If your patient's balloon is continually inflated, it will kill them because you are occluding their pulmonary artery and they cannot oxygenate their blood. So I hope that this was helpful. Like I said, I will set up a video with 7 West. They have a really experienced nurse down there that's absolutely wonderful at helping us set up swans. He's helped me do it multiple times, and I'm going to get together with him and make a video of how to do it because it is pretty complicated. There's a lot of cords and wires. If you guys have any questions, please feel free to reach out to me, text me, comment, whatever you guys want. I hope this was helpful, and next month, early April, we're going to try and go ahead and do our ventilator meeting of the minds. I know we were going to do neuro, but I think with everything coming up in the near future, it would be helpful for us to have a review of mechanical ventilator, management. Thank you guys for listening. If you have any questions, just let me know.